welcome everybody to another expert talk in our expert talk series. Today's presentation is titled, "Is ALS a Recoverable Disease? Insights from Tofersen and the Role of Peripheral Nervous System Plasticity." And our presenter this evening, or this afternoon, is Dr. Brett Morrison. And Dr. Brett Morrison is the Associate Professor of Neurology and Program Director of Neuromuscular Medicine Fellowship at Johns Hopkins University. Dr. Morrison specializes in neuromuscular disorders in adults, including peripheral neuropathies, amyotrophic lateral sclerosis and ALS, myasthenia gravis, and muscle diseases. Dr. Morrison's been the site principal investigator for clinical trials investigating new treatments for chronic inflammatory demyelinating polyneuropathy, or CIDP, painful diabetic peripheral neuropathy, and ALS. Dr. Morrison's research interests include investigations into the mechanisms of nerve regeneration following injury, the biology of support glia in the brain and peripheral nerves, and improving understanding of the pathogenesis of motor neuron degeneration in ALS. His current research focuses on better understanding the role of the immune system in the peripheral nerves and targeting these pathways for the development of new treatments. Dr. Brett Morrison received his MD and PhD from Mount Sinai Medical School in New York City, and he completed his medical internship at the University of Maryland and residency in neurology at the Johns Hopkins Hospital. He then completed his fellowship in clinical neurophysiology at the Johns Hopkins Hospital as well. With that, we'd like to welcome Dr. Morrison, and I turn it over to you.
Great. Well, let me share my screen here. And I just wanted to thank the organizers of EverythingALS and Christian and everybody else for inviting me to speak here. I always appreciate the ability to talk directly not only to other experts in the field, but obviously also to patients and caregivers about ALS and various aspects of ALS treatments. So I don't know if any of you were at the Muscular Dystrophy Association annual meeting this year. If any of you were, you might have heard a version of this talk before. This will be a little bit different, but it's based on that talk that I gave at the Muscular Dystrophy Association meeting. As was mentioned, title of my talk is ALS a Recoverable Disease? Insights from Tofersen and the Role of the Peripheral Nervous System Plasticity. So I don't have to tell this group what ALS is. ALS is a progressive disease, progressive weakness, and it's due to degeneration or loss of both upper motor neurons and lower motor neurons. For disease-modifying therapy, as this group well knows, there's really two therapies that have been approved for disease-modifying therapy of ALS, and that is Riluzole and Edaravone. In addition to that, treatments certainly are lots of treatments associated with supportive care, lots of clinical trials that are going on. But at this point in time, those are the only two that are approved for all types of ALS at least. And survival is not what we want for this disease, encouraging us to continue to do research. So first thing I wanted to just talk about was the distinction between sporadic ALS and familial ALS. The vast majority of patients that have ALS have sporadic ALS. And what we mean by that is that's ALS that is not directly genetically inherited or genetically caused from, passed down from one of your parents, essentially. It is, as I said, the vast majority, such that about 90 to 95% of people have a sporadic ALS that is a non-genetic form. The genetic forms, however, have been very important in us, one, learning about the different mechanisms and causes that seem to underlie why ALS occurs, the direct pathology that occurs, the mechanisms that are underlying the disease. And it turns out that many of these genetic diseases may be easier to develop treatments for, at least initially, right now, than does sporadic ALS. And so when we're talking about familial ALS, there are multiple different genes. There are multiple different parts of the DNA that can be abnormal. Um, and this is just a little pie chart here. Let me get you, I'm going to get a pointer here. Let's go over here and do a little laser pointer here. And so this is a pie chart over here on this side, just breaking down the percentage of patients that have different genes mutated in ALS. And certainly the most common one is this C9orf72. This is one that was found just about, I don't know, probably like 12 years ago at this point. The second most common is SOD1, that's superoxide dismutase 1. And this was the first gene that was found to be causative for ALS. And this was found back in the 1990s. And then there's a number of other genes that have been found, and this is just showing the most common ones, but there's many others that fill in this other group right here. And there certainly are a few that we haven't yet identified. Importantly, all familial ALS and sporadic ALS, for the most part, have very typical similar symptoms. So they still progress about the same. And in fact, we cannot necessarily tell the difference between somebody that has genetic ALS versus a person that doesn't just by meeting them, talking to them, or examining them. We really need to do genetic testing. So this is just a little series of tables here, which really show the development and the progression and our greater understanding about genetic ALS. And so beginning in 2005, these were the genes that we knew. I told you SOD1 was the first one found. It was therefore called ALS1 ultimately. But by 2005, we'd known, just about 8 or 10 genes that caused it. By 2020, that had doubled. And now by 2020, you can see the number of genes that we see here. It's in the order of about 30, 35 genes, and there's many more being discovered all the time. So out of all of these genes, probably the one that we best understand and the one that has certainly been studied the longest and the most is the SOD1 gene. And so circled here, right here. And so as I've showed in the pie chart, that makes up about 20% of patients with familial or genetic ALS. So taken as a whole, it only represents about 2% or so of all of ALS. So it's a very small amount of all of ALS, but a relatively decent percentage of patients that have the familial form. So it was then quite a big deal when the first treatment for this type of genetic ALS was developed. And this treatment, which is now called Tofersen, or Qalsody is the other name that you'll hear about it, was ultimately licensed by Biogen and approved through the FDA for the treatment of patients, really only for patients that have the SOD1 mutation causing their familial form of ALS. And it's the treatment itself is what we call an antisense oligonucleotide. Essentially, this is a sequence of nucleotides that will bind to or match up with the superoxide dismutase in patients, and essentially leads to degradation of that SOD1. And so by degrading the SOD1, essentially they're lowering the amounts of this mutated SOD1 that is present in patients. The treatments are not easy in that this is not a pill, this is not even an IV injection. These treatments are given intrathecally, which means an injection into the fluid around the spinal cord. The first 2 doses are given every 2 weeks, and then following that, the doses are given monthly after that. And the pivotal study was published here in the New England Journal of Medicine in 2022, which was a study of 72 patients with SOD1 ALS, randomized 2-to-1, which means that for every 3 patients entered in the trial, 2 patients got the active treatment and 1 patient got a placebo. And the trial was 6 months long, plus there was an open label extension. And so just to kind of show you a little bit of what some of the results were of this study, the first thing to know is this first part called Valor. That's the part of the study where it was blinded, where some patients got the treatment and other patients did not. And so we measured a bunch of different things, or the investigators that did this study measured many different things during this study. The first thing they measured was just SOD1 levels, right? So this is a treatment that should lower SOD1, and therefore we wanted to see if that actually happened. And so, what you have in blue here are those that were getting the placebo, and so they had no lowering of their SOD1. Whereas the red here that got the treatment, you can see a nice clear lowering to, about about 60, 65%. So about 35%, let's say, reduction in the amount of SOD1 in those patients. What happened here with this dotted line was that all the patients then that were in the placebo group were then given active treatment. And you can see that when that happened, they rapidly reduced to the same level as those that were getting the treatment from the beginning. Another thing that we used, which you guys are probably familiar with now through it's being used in many clinical trials and is used in clinical practice by many practitioners, is this neurofilament light chain, which is a biomarker for ALS. And what was found in this study was, again, the people getting placebo had no change in their level of neurofilament light, whereas there was a marked reduction in the patients that got the active treatment. And again, in the open label extension, when those in the placebo actually got the treatment, they also had reductions of neurofilament light chain. And it's thought that neurofilament light chain, lowering the levels of neurofilament light chain, is reflective of reduced neurodegeneration or reduced loss of neurons in this disease. So it's a good thing when that value comes down. Other things that were measured in the trial were the ALS functional rating scale, vital capacity, handheld dynamometry, and then also a survival curve here in terms of survival for the patients. And for most of these other values, at least during this initial part of the trial, there was some separation between the groups, meaning that, again, here, so for ALS, this is for ALS functional rating scale, you can see that this is, again, the placebo group had a greater decline than did the group that got the Tofersen to begin with. But this wasn't actually significant. There's some separation here, but with the number of patients that were enrolled in the trial, this was not a significant difference. And that was also the case for many others of these measures as well, where we saw essentially trends, what we'd call trends to improvement without significant changes, at least at the point of where essentially the placebo-controlled part of the trial ended. Once that ended and we had open label extension, interestingly, the patients that continued and now have gotten for a whole year had gotten, so this is this group here actually. So the patients that had gotten the Tofersen for the whole year, compared to those patients that didn't get it for 6 months but then got it, there's now a pretty good separation between them, right? So the patients, what that tells us is that even though there was nice reductions in superoxide dismutase once these placebo patients got the treatment, there was something about starting the treatment early, and that starting it later certainly did not lead to the same degree of improvement. And that can be seen not only in ALS functional rating scale, but also in the vital capacity measurements and the handheld dynamometry score, which is our measurement of hand strength, essentially. In terms of survival, there was definitely again a trend towards improved survival in the red line here, which is the ones that had the Tofersen from the very beginning, compared to those that just got it late. But there's not huge separation between these groups. So ultimately, based on these results, particularly quite honestly, the neurofilament light chain result, I think was one of the things that was most convincing to the FDA. But based on these results in totality, this medication was approved in April 25th of 2023 as Qalsody or Tofersen for the treatment of SOD1 ALS. And so that was although it only impacted a few of our patients, it was really important to those patients that were affected. SOD1 ALS is a bit of a heterogeneous disease in that, similar to other types of ALS, but some patients with SOD1 ALS can have a very rapid course, and this allows treatment of those patients and offers some hope for them for stabilizing their disease. So what then caught the attention of many of us who have had patients now that have been taking Tofersen, and was then really put into text or put into a paper here in this paper that came out from the Washington University in St. Louis, which is really, I must say that Tim Miller and Washington University is where all of these treatments were developed. Much of the preclinical work was done, and they have a very large population of SOD1 ALS patients that they follow at WashU. And so they put together this, essentially it's just an observational study. So there's no control group here. But they wanted to just show what is happening to these patients that are getting Tofersen over a longer period of time. And so here the mean time of treatment was now the mean time to treatment, sorry, was 5 years. So some patients had quite a bit of a delay till they got the treatment. Again, because this was done on some of their earlier patients that prior to the treatment being approved. And the average duration of treatment on Tofersen was about 18 months here. But it varies. Each patient is different. And then what they looked at then is looking across these different patients, they looked at different characteristics. So they looked at different measurements of how their ALS was progressing. And so, for instance, they would look at the ALS functional rating scale. And then what you have here is you have blue, which is kind of the baseline for the patient. So whenever prior to starting treatment with the Tofersen, the orange is what their value was once they whenever this trial was stopped. And again, that's on average 18 months, but some patients were 6 months, some patients were longer than that. They vary between the patients. And you can also see that there's quite variability in how severe the patients were, right? Some having very low ALS functional rating scales, some having higher ones, okay? But what we see here is that in general, the patients that who were treated had either stable scores, meaning no decrease in ALS functional rating scale over, again, at average 18 months, or improvement in some of these patients. Many of these improvements were quite small, but there was some improvement. And then what you have in the gray here is what we would have expected, and these are just historical controls for this patient based on how long they'd had the disease. And so, first of all, you can see that the patients did much better than you would expect compared to historical controls, and that's pretty obvious to see. But in addition, there were definitely some patients that seemed to have some clear improvements of at least a couple points on the ALS functional rating scale during their treatment. Other measures that they did were, this first one up here is handheld dynamometry. And again, looking across these 6 patients that they measured it in, 5 out of the 6 had some improvement. And really, at least 3 of them, this one here improving from 597 to 721, this one from 611 to 644, and this one from 410 to 599, 3 of them had pretty profound, actually, improvements in handheld dynamometry. And this is down here is kind of a functional independence score. And again, in this case, all 6 of the patients improved, some quite modestly, but others quite significantly, actually. Obviously, without treatment, we wouldn't expect any of these things to improve. We would have expected further weakness. But the thing that struck us about this study that was published, but also in many of the patients that we see, is that we really do see patients actually improve on the treatment, which to many of us was maybe a little unexpected. And just to kind of finish the results, and this is the last results page on this from this published paper, was looking at 3 other measures here, this is the 10-minute walk test. Again, improvement in all 4 patients that had that test done. The timed up and go test, again, improvement in pretty significantly in 3 out of 4, and I'd say 1 was pretty stable. And then sit to stand was improved pretty significantly in at least two of the patients. Okay. And so interestingly looking at this, as I said, like we had always hoped that if we could find a treatment like this that would be a really highly effective therapy for ALS, that we would be able to stop the disease, right? That's been always the goal. Um, and I think it was somewhat unanticipated that there would be this much significant recovery for at least many patients that take this medication. Um, and so got us thinking in terms of why that is. Why are patients improving? What does that mean for perhaps developing therapies that can be adjunct therapies to perhaps accelerate that recovery in patients that are receiving these sort of highly effective therapies. And let me say that right now we only have this type of highly effective therapy for this small group of patients. But we certainly hope to develop these highly effective therapies for other patients as well. Probably first for other patients with genetic ALS, because those are a bit easier to understand. We understand what starts the disease in those patients. So in many ways, it's easier to turn off that disease for patients with genetic ALS. But ultimately, we certainly hope to have those sort of treatments for patients in sporadic ALS as well. So although this doesn't apply to other patients besides SOD1 right now, I would hope it would in the not too distant future. So in terms of potential mechanisms for improved function in SOD1 ALS patients treated with Tofersen, we really thought about it in terms of different areas of the nervous system in which there can be plasticity that might allow improvement. So plasticity is a term we talk about in medicine, which basically says that the brain and the nervous system and really other parts of the body, but we talk about it in neurology in terms of the brain and the nervous system. There's many things that are hardwired there, right? There's neurons, their connections are set. But it turns out that those can be modified over time, and that there's great ability of plasticity, great ability of the brain to accommodate and change, and make up for deficits that occur due to injury or due to disease. So there's plasticity in the cortex and the spinal cord. For instance, some very obvious examples are, many of you may know, or you yourself may have had, like a stroke, for instance, right? And a stroke is where you get a vascular injury that literally kills a part of the brain, and that leads to weakness or numbness or a series of symptoms. Over weeks to months afterwards, most patients with strokes improve significantly. And it's not because they're regrowing new neurons. It's because the neurons around them have plasticity and they're able to take over the function of those that are injured. Similarly, there's some patients that get seizure surgery, especially little kids that have really horrible seizures from birth. And some of the treatment for that, it can be to literally take out large areas of the brain to stop the seizures from happening. When that happens, they originally can't move the other side of the body away from the side that had the cortex removed. But over time, those kids learn to use that side, and oftentimes that side can function almost indistinguishably from the other side, again, showing this plasticity. Similarly, there can be repair of the motor neuron environment, right? So in terms of the motor neurons don't exist in a vacuum. They don't function in a vacuum. There's many different cells around them. We mostly call them glia, which is a term that actually is a Latin term that means glue, actually, is how they were originally thought of. But here we're talking about cells that are called like astrocytes or microglia or oligodendrocytes, and also some of the immune cells that are in the brain called microglia. And those cells have been shown to be very important for supporting neurons, supporting motor neurons, keeping them alive even in the setting of disease, and in some ways actually improving their function if they're injured. So perhaps there could be repair of those cells. Recovery of sick or dysfunctional motor neurons. And I'm gonna talk more about that in a moment, so I'm not gonna belabor that point right now. And then finally, regeneration or sprouting of peripheral nerves and recovery of muscle as well. So every one of these motor neurons basically talks to the muscle through the peripheral nervous system, through peripheral nerves that are basically cables that run from the motor neuron to the muscle. And it turns out those cables have the ability to regrow and regenerate. And we think that that can happen in many different conditions and diseases. And perhaps this is one of the reasons why those patients recovered following the Tofersen. So moving on in terms of recovery of sick or dysfunctional motor neurons. So there are many examples of this, okay? And I'm just going to show, just by putting the title of some of the papers, a few of these. So certainly this has been seen in toxins. So lead, for instance, and mercury are toxins that can affect the motor neurons and can lead to weakness. But when you remove those toxins, depending on the severity of the injury to begin with, much of the weakness that occurs actually later improves. So these have been termed reversible forms of motor neuron disease because of that back in 1974 in this paper. Additionally, cancer is another cause of motor neuron injury or motor neuron disease. And again, in some of these cases, when the cancer is treated or the cancer is removed, the patient can have recovery of function of their motor neurons in their motor function. Now, again, the recovery is not usually complete, but the recovery can be quite significant for many patients. And finally is a big group of infections. And this really started with polio, right? I mean, I don't, if any of you know patients or you know people that have had polio. I certainly see some in my clinics. But these are kids that have polio as a kid and they can be completely paralyzed. And if you can keep them alive through the paralysis, then most of them then later improve in life and can have what amounts to almost normal strength and in their adulthood. And it's really impressive, the recovery they have. And this was initially seen in polio, but has been seen in other viruses as well, West Nile virus, HTLV, HIV, so a series of different infections that can all impact the motor neurons, but from which patients can recover. So secondly is, and this is going to make up the greater part of my talk, because this is actually the area that I myself do research in, is that there's great capacity for recovery in the peripheral nervous system. And so when you're talking about the peripheral nervous system, I'm really talking about, here's your motor neurons sitting in the spinal cord. They send out what we call axons, which make up this nerve that is the cable or the connection that goes to the muscle. And so we're talking about the peripheral nerve itself here. Here's the peripheral nerve again. We're talking about the terminal branches, which are the endpoints of these nerves that come into the muscle. We're talking about neuromuscular junctions, and then we're talking about the muscle itself. Improving or any of these areas can lead to improvement in function for patients that have had motor neuron disease. So just first of all, in terms of regeneration of peripheral nerves, a lot is known about regeneration of peripheral nerves, and it turns out your peripheral nerves regenerate quite well. This was first described here by Augustus Waller back in 1850. And a lot is known about this now, but essentially when a nerve, and most of this is known not from ALS, but is known from nerve injury. And so if you injure a nerve, what happens is that there's a series of events that happen that lead to first the cells, a series of immune cells coming into a part of the nerve and clearing what essentially is now dead nerve that has after the spot of the injury. But by clearing away that dead nerve, it then encourages the nerve to regrow. And then ultimately the nerve regrows and can reinnervate or go back to the muscle and be again a functional nerve. This process happens. It happens very slowly. And how successful this process is really depends on how long the nerve has to regrow. So if you, for instance, have a big cut on your finger, you might notice that maybe your finger is numb, distal or in the tip of the finger afterwards. As that cut reheals over weeks, you might start to feel like the sensation comes back in that finger over time, and that's due to regeneration of the nerves happening. So why would regeneration be important for motor neuron disease? Well, this comes back to some studies that were done and some papers that were published back in 2004 and then again in 2011, which really suggest that there's some suggestion that even though this disease, ALS, is caused by motor neuron degeneration. And we oftentimes focus on the cell bodies, which are the parts of the motor neuron in the spinal cord. But it turns out that some of the areas where the motor neurons are most affected early in the disease, at least in animal models where this is easy to assess, is it the most distal part? Is it the part of the motor neuron that's right at the level of the muscle? And that was seen very clearly here by Lindsay Fisher, who's now Lindsay Hayes, in Jonathan Glass's lab back in 2004. But was also suggested in this paper in 2011, which was actually done in a patient who died early during a surgery, not from their ALS, who ended up having lots of muscle denervation without really any loss of the motor neuron cell bodies themselves. And there's been other case studies that suggest this as well. So what that means then is if you could stop the degeneration process, perhaps just by regrowing the nerve, you could get improvement in function. Perhaps that's part of what's going on here. And so if that's the case, if nerve regeneration is part of the reason why these patients getting, for instance, Tofersen are improving, are there ways of accelerating nerve regeneration? Is there ways to improve this, right? And can we learn something from the studies that have already been done with nerve transections or nerve injuries in terms of trying to accelerate nerve regrowth in those situations to potentially help patients with ALS that are receiving highly effective therapies? And so there's been a number of different techniques that have been evaluated, and many of these, and I'm not really going to go into this for the sake of time, but just realize that there are a number that have been investigated or are being investigated. So far, none of these have been approved for treatment, and there's various reasons for that. Many of them are side effect reasons or ability to target the nerve as well as we want to. But people are working on these techniques for sure. For we just to say that I in my own lab am working on this as well. And what we're really focusing on is we're focusing on one of the immune cells in everybody's body, which is called a macrophage. And a macrophage is one of those immune cells that is really important for nerve regrowth. And so we're really trying to change the macrophage by giving treatments or genetic changes right now or other ways of trying to alter macrophages in order to accelerate or improve nerve regrowth. And these macrophages are involved in a number of different things in nerve regeneration. They're involved in clearing away the dead nerve that I mentioned before. They communicate with other cells that are important in nerve regeneration, like Schwann cells, and they're really important in recruiting blood vessels, which are important for providing energy to the regenerating nerves. And so we have done a study in my lab. I'm not going to go through the details of this, but needless to say, we were able to genetically change these macrophages and find that this led to here, this is what a control nerve recovers to, and this is electrophysiology for those that this is similar to when you go in as a patient and or you've seen your loved one perhaps get this sort of a study done where you go in and get the EMG nerve conduction study. This is really that sort of study, except we're doing it on an animal model. But what we see is this is the recovery by nerve conduction studies in a wild type animal. But then in an animal with these manipulated macrophages, we get more recovery here, as you can see in these two graphs here. And similarly, when we looked at the degree of reinnervation, the degree of nerve that got to the muscle, we saw improvement as well in these manipulated macrophages. And there's been a number of other studies that have also targeted these macrophages through various techniques that have shown that changing macrophages can be a way to accelerate nerve regrowth. Now, as so far, these have not reached the point of helping patients yet, but I certainly hope in the not too distant future that we'll have techniques that'll be able to do that. The next area that I just wanted to talk about is the sprouting of terminal branches. And so here we have not an injury to the nerve way up top, So actually, let me say it this way. So here, this is what a normal, let's say, a couple of nerves. So this is a motor neuron. This would be the nerve that comes from the motor neuron coming down to the muscle. And here we have two side-by-side motor neurons in a normal muscle that has no problems. Here, if we have an injury here to the nerve, or you could also think if this whole motor neuron was taken out, this would be the same thing. You basically have loss of the nerve that normally goes to this muscle. Well, does that just mean that this muscle just exists and it's never going to get is never going to contract again because it doesn't have a nerve. Well, the body tries to recover from that. And one of the ways it does that is with what's called sprouting. And so there's, even though this is one nerve here, there are parallel nerves coming from different motor neurons that perhaps are still intact. And what they can do is they can send off these sprouts, just little sprouts, these small nerves that can then go to the muscle that no longer has a nerve going to it and allow that muscle to contract, right? And this is called sprouting. And this can happen dramatically to the point that as these motor neurons are lost, the motor neurons around it will try to sprout and can go to basically 10 times the amount of muscles that they previously went to. So that allows for a massive increase in what we call motor unit size, and allows some recovery. Now, in the setting of ALS, ultimately, this motor neuron here, if there's no highly effective therapy, this motor neuron will also be lost, right? And that's why this compensation only lasts so long in a disease like ALS. If this is a disease more like partial nerve injury, however, this can be a permanent solution. And this also may be something, however, that can be effective if we can get a treatment now that will protect this motor neuron from ultimately degenerating, as perhaps is being done with Tofersen, and hopefully with other types of ALS in the future. So the next question would be, are there techniques to improve sprouting or improve the effectiveness of sprouting? And so there really have been two treatments that have been shown, NOGO-A and BACE1 inhibitors, to improve this sprouting or the durability of sprouting. And so this NOGO-A was first evaluated in one of these ALS models. It was actually the SOD1 model, so the same mutation that's found in patients that are being treated with Tofersen. And so what it found is that NOGO-A actually restricts the sprouting. And so if they put in an inhibitor, something that blocks NOGO-A, they could actually delay disease progression in this mouse model of ALS, by basically improving sprouting and keeping sprouting going. Now, unfortunately, they did try this in a clinical trial and it failed. And I would say that it failed because there's just too much rapid degeneration occurring. And even if they're sprouting, remember, once that motor neuron that's sprouted degenerates, all the muscle fibers that goes to are also going to lose function as well. Similarly, BACE1 is another compound or protein that's been studied. It's a membrane-bound protease. It basically, inhibition or blocking this BACE1 improves axon regeneration and the amount of terminal sprouting that occurs. It was effective in improving innervation in a mouse model of ALS, so it did help this sort of sprouting in a mouse model. It has not yet been tried in a clinical trial. And then the last area that I'm going to talk about is improving strength and contractility of muscle, because I think this is another target we could have for patients treated with Tofersen, but then also, again, other patients perhaps getting highly effective therapies. As we all know, muscle atrophy and weakness are really the primary feature of ALS. It occurs because there's loss of nerve going to the muscle, denervation. As a muscle becomes reinnervated, it can increase its size and strength. And so people have tried over the years to come up with therapies to basically improve muscle size or to improve essentially muscle contractility, the amount of strength the muscle has. And two therapies I'm going to talk about are these myostatin inhibitors, and then also a group of treatments which are called fast skeletal muscle troponin activators. So in terms of myostatin inhibitors, myostatin is a protein that was found many years ago. It basically inhibits or stops the growth of muscle. So what that means is that inhibitors of myostatin can make muscle grow more. And this was actually results from a study that I did long ago in a mouse model of ALS, in the SOD1 transgenic model. And we essentially treated these mice with a pharmacologic inhibitor of myostatin and showed that, the normal decrease in grip strength here, this is forelimb grip strength and hind limb grip strength, we saw improvement in that grip strength in those mice that were treated with this compound as opposed to those that didn't. So it improved strength in the mouse. It ultimately did not actually prevent the mouse from dying, however. And again, this is likely because the motor neurons were still degenerating. We didn't stop that process. So the disease process continued. But we were able to make them stronger in the meantime. But kind of proof of principle that this might work or be helpful in the Tofersen patients is a study that's kind of ongoing now in spinal muscular atrophy. So many of you will be aware of SMA or spinal muscular atrophy. This is also a motor neuron disease. It's a genetic motor neuron disease. Oftentimes, the majority of patients are young kids that are affected with this. But this is another disease where we have highly effective treatments for this genetic disease. The first of those was this compound called nusinersen. And so what they did with myostatin is we now have good phase 2 clinical trial data that's been published showing that treating patients that are getting nusinersen to basically stop the progression of their disease, treating them with myostatin inhibitors actually leads to further improvement in their function and recovery. So it appears that way in phase 2, and the phase 3 is ongoing for more definitive proof of this. And then finally, this is the last data slide I'm going to show, is with reldesemtiv, which is one of these fast skeletal muscle troponin activators. So what these do is they don't actually improve muscle size, but what they do is they improve muscle contractility, how much a muscle is able to contract, or how strong, essentially how strong the muscle is for a given amount of activity from the nerve. So the muscles activate better essentially. And this was data from a phase 2 clinical trial done by Jeremy Schaffner and his group. And so there was some suggestion from this trial that at least for patients that had basically had more rapidly progressive disease, or here they call them moderate progressors versus slow progressors. But at least in the moderate progressor group, there appeared to be a pretty good sized difference in terms of treatment, in terms of the decrease in ALS functional rating scale. So these here are the patients that didn't get the treatment, and these are those that did. So there seemed to be a pretty good separation there. And this is total ALS-FRS. When they break this out between fine motor and gross motor, it seems that most of the change they were seeing was in a gross motor score here. So it seems to be improving not so much hand function really, but perhaps more proximal muscle strength here. Unfortunately, this is another trial that failed in ALS, and the phase 3 clinical trial did not show success, at least in its primary endpoints here. And again, that may just be because the disease is progressing too fast for this to be helpful. So in summary, the source of recovered function following Tofersen treatment, we don't know for sure, but I suspect it was from multiple things. It was from recovery of injured motor neurons. It was from regeneration or sprouting of axons or nerves back to the muscle, and potentially could be from some muscle hypertrophy. These patients in the trial, perhaps they then, as they started to feel better, started to exercise more, and therefore could get hypertrophy of their muscles that now had preservation of the nerve going to them. And potential peripheral targets to improve recovery would be to accelerate nerve regeneration, increase axon sprouting, or improve motor strength. And so just a few take-home points from this talk. So the take-home points I'd like to leave you with is that the nervous system really has great plasticity. It will respond to motor neuron injury and does respond to motor neuron injury in all patients with ALS, actually, with attempts to recover function. This plasticity certainly occurs at the level of the brain and the spinal cord. I didn't really talk much about that during this talk for the sake of time, but also the recovery of sick motor neurons. And I showed you examples of viruses and other things that can cause this, but this also likely happens in ALS as well, where certainly some motor neurons have degenerated and they're not going to come back if we treat those patients with Tofersen. But there are some motor neurons that are just likely on the way to degenerating that are sick, but haven't yet degenerated. And those ones, if you give them a nice effective treatment, they can then recover and potentially recover their function as well. But then also nerve regeneration and sprouting, which I did talk about. I feel like these attempts are primarily futile and not likely to be overly effective as long as motor neuron degeneration continues to occur. So until we can at least greatly slow down motor neuron degeneration more than we're able to currently with patients with sporadic ALS, these types of add-on therapies likely are not going to be that effective. But when motor neuron degeneration is stopped, as for Tofersen currently, but hopefully for other treatments in the future, for genetic ALS, perhaps for some types of genetic ALS in the near future, and for sporadic ALS, hopefully in the not too distant future, we might have better attempts at improving function by combining therapies with some of these other attempts at improving plasticity. And so that is what I want to talk to you about. But I'm happy to take any questions, and I'm going to stop sharing this so that I can see faces and can see anything that people have put into the chat in terms of questions. So.
All right, thank you so much, Dr. Morrison. Let's see, we're going to unpin real quick or remove the spotlight so we can get the whole community involved. And we do have some questions from the community. So Anusha and I are going to take turns taking the questions to you from the community. So the first question is from one of our community members who said that they have a C9 mutation and TPN 101 is coming to their clinic in the fourth quarter of this year. They understand that TPN 101 targets the C9 mutation. Is there anything you can comment on that explains that further?
Yeah, so I mean, I think so. Similar to SOD1, obviously C9 mutations are the most common cause of ALS. There are a number of groups that have tried to develop types of genetic therapies to target C9. The first therapies that they've tried were not effective in the clinical trials that they tested them in. But the companies have basically tried to essentially attack the gene in different ways to try to perhaps more effectively block the downstream negative impacts of the gene. And so we have great hope and promise that these other therapies targeting the gene will be effective.
Thank you.
All right, Dr. Morrison, the next question is, are they looking for less invasive ways to administer Tofersen?
So yeah, I think that's a great question. I think that the answer is yes. That certainly, I'd say in general that the ALS field is far behind I mentioned the spinal muscular atrophy is another disease, another neurologic disease, actually another motor neuron disease in which we have really highly effective therapies. And they're quite a bit further along than we are. In SOD1 ALS, we just have the one approved treatment right now. They have multiple treatments for SMA. And some of those treatments are making it easier to get the intrathecal treatments, meaning that they have to be given less often. They're not given monthly. They're given several months spacing apart. Some of the treatments are just given once. They're literally treatments that change the genetics so that it's no longer just blocking the effect of the gene. It's literally changing the gene. And I think those can be potentially something that could be investigated where you could get one treatment for ALS that could be more long lasting. And then third, they are developing treatments for that disease that can be given systemically. And certainly in ALS, that's a possibility too. In many cases, these are done through other carriers, sometimes viruses we use and other sorts of carriers that can be given systemically, meaning into the bloodstream, and then can actually travel themselves into the nervous system without having to be injected into the spinal cord. So yes, there are many attempts to try to develop these treatments that'll be easier for patients to get on a recurrent basis.
Thank you.
So the next question is from a member of the audience who did not test positive for a genetic form of ALS, and when they started Relyvrio, their ALS FRS was actually down to about 20, and now it's currently 37, but they took the medication off the market because of the phase 3 trial was only about 23% effective. What can be done to keep medications available for the small percentage of people that when it works for them?
So, okay. So I think that's a great question. It's not a question I think that I have a great answer to. I certainly hear your concerns, and I also had some patients that also could had some effectiveness with the treatment that I think you're talking about. And I believe the treatment you're talking about is probably Relyvrio, which I think is the treatment that was originally approved for ALS, and then they retracted that. So, I think that in some ways, you know, clinical trials are difficult in that we need large number of people, and we're looking for big trends, meaning that we're looking for in a significant number of people, there's improvement. Disease of ALS is certainly quite heterogeneous, and it may be that some treatments are only effective for a few people. And if that's the case, if we do a big clinical trial, that might be lost. So I think it behooves us as investigators and to continue to look to see who are the patients that are truly responding to these treatments, even if they're not any longer approved, to understand if perhaps there is, a subset of patients perhaps that would benefit from these treatments. And then we could do a clinical trial where we just target that subset of patients, right? That's been done for other treatments, and potentially that could be done with Relyvrio or other treatments that appear to fail in clinical trials. But I certainly can understand and sympathize with the person that asked that question.
Thank you.
Right. The next question is, what is known about recovery of nerve function in transplanted human hands?
It's not an area I know too much about. I think that it would all depend on I think when the transplants occurred, or I guess I would probably need further clarification of that. Certainly if somebody had an acute injury, let's say they had an injury at work or something where their hand was cut off, and then when you do that, obviously you're going to sever every single nerve that's there. If that hand can be reattached relatively quickly, then you will certainly get nerve regrowth back into the hand. May not be fully complete, but there'll be some nerve regrowth back into the hand. It's also true that some patients that have had longer, let's say it's been a longer period of time, or that they have a prosthetic hand or something. There's some prosthetic hands they're now doing that can have actually the nerves will connect into the prosthetic hand actually, and can get artificial movements of the hand through your own nerves. So in those cases, the nerves are showing a plasticity as well. But I guess I would need further context of that question, I think, to fully understand it. But I think that mostly in terms of recovery of a nerve, it depends on how long it's been since it was injured. Because after it's been injured for too long, the nerve will lose the ability to recover after a period of time.
Right. Thank you.
Thank you. What is known, or what could you comment on in terms of the recovery of nerve function? I'm sorry. Does Avastin slow nerve regeneration? That was the next question on the list.
Does Avastin slow nerve regeneration? Not that I know of. I don't know. Does Avastin? Oh, that's the whole question. Does Avastin show slow nerve regeneration? Avastin. Avastin. What Avastin is, for those that don't know, Avastin is a VEGF inhibitor. It is used to treat a number of cancers nowadays, and I think as a VEGF inhibitor, it would likely. I'm just going to talk myself through the answer here. So, as a VEGF inhibitor, it would likely prevent or slow the recovery of blood vessels. So yes, actually, I would answer my question. I would reverse my answer. And I would say that Avastin, yes, just took me a moment to click into what Avastin was again. But Avastin, yes, would likely probably slow nerve regeneration in patients that are taking it for cancer reasons. It's not a reason. I mean, obviously, they're taking it for important reasons to try to control their cancer. And as far as I know, I don't think that Avastin has been shown to actually cause peripheral nerve injury, meaning that it's not going to cause you a problem. But I suppose if you did have some sort of a serious nerve injury while on Avastin, it would likely impede the recovery from that. Yeah. It's a very high level question right there.
Thank you.
All right, the next question is, are macrophages considered a type of glial cell?
They're not. They're considered an immune cell. They're one of your white blood cells that we have. So, you have lymphocytes and macrophages and neutrophils. Those are the main population that make up the white blood cells. So if you ever saw if you ever saw a CBC, like your own blood counts, one of the things they measure is something called WBC, which is white blood cells. And macrophages are part of that population of cells. The glia cells are cells in the central nervous system, are astrocytes, microglia, and oligodendrocytes. And in the peripheral nervous system, meaning in the nerves, it is Schwann cells or the glia. But it's a different group of cells. We don't tend to lump them together as a glia.
Thank you. Is there a theoretical maximum motor unit size, or is it stable with aging?
Great question. Really great question. I don't know if there's I mean, there certainly is a maximal limit. I don't know. I must admit, I haven't read into the literature of whether there is a theoretical limit to that, biologically, I don't know what that would be. I do think, however, the question of does it change with aging is a great question. And I think evidence would tell us that it probably does. And much of that evidence comes from, I mentioned the disease polio, and much of our evidence comes from patients with polio. Because patients with polio, one of the reasons they recover for a number of reasons, right? One way they recover is certainly because they have sick motor neurons that just become unsick. They recover, they get healthy. But there's a number of motor neurons that have been lost in patients with polio, and yet again, they can have almost no symptoms after they recover. And so part of what happens is as I mentioned, is that you can get quite a bit of sprouting that occurs in that disease. And there we really see these large motor units, one single motor neuron going to a number of different muscle fibers, for instance. And those patients get something that's called post-polio syndrome is the term for it. Nobody totally understands post-polio syndrome, but one of the hypotheses, one of the reasons why we think that might occur is that with aging, the sprouting becomes less supportable. So that motor neuron perhaps as it ages, is no longer able to support, let's say, enough sprouts to go to 10 muscle fibers or 8 muscle fibers or whatever it's going to. And then it starts kind of losing some of those, right? And maybe some people think that even that motor neuron being overextended for such a length of period of time actually can lead to perhaps even degeneration of that motor neuron because the motor neuron gets sick. Now, again, we don't understand fully post-polio, but I think that it's reasonable to think that with aging, that this is going to be these sort of plastic processes that are occurring in the peripheral nervous system might be harder to maintain over time.
Thank you. The next question is, does SPG 302 potentially improve reinnervation?
Does SPG 302 improve regeneration? I must admit, I'm not familiar with what SPG 302 is right now. So maybe somebody can enlighten me on the call.
Yeah, Brett. So this is Lyle. Hey. So you're going to be embarrassed because this is the Rita Sattler drug. So, so Rita Sattler was a former lab mate of both Brett and myself, who did a lot of work with nerve sprouting and encouraging nerves to promote new growth sprouting. And that drug is from a company called Spinogenics that basically developed this strategy as a treatment for ALS and got a large grant from the Department of Defense, from the CDMRP, in collaboration with Dr. Sattler, who's now at Barrow, and another lab in California to develop the preclinical work that turned into that drug. And so the purpose of that drug from Spinogenics is indeed to promote nerve sprouting. We don't know if it works yet, but we're hoping. So, but it was something that originally came out of the lab of somebody that Brett and I used to work with.
Great. Well, she wasn't working on it when she was here. I can guarantee that.
That's true.
But it is. Thank you, Lyle, for educating me on it. And I'm always appreciative to learn something new. So I will follow that up for sure. All right. Any other questions that are on your list here?
Yeah, we've got a few more. Since all clinical trials require fast progressors, it seems like, how can we study therapies for nerve regeneration if that's the case?
That's a great question. I think that overall, I think it's going to continue that fast progressors and those with early ALS will continue to be those patients that are getting enrolled in trials to try to slow the disease or halt the disease. So, what we would think of as like classic um, disease modifying is not really the right word, but treatments that are designed to protect motor neurons. I think it makes perfect sense that they're doing that. I actually think, though, if we were going to do a trial of some of these more supportive mechanisms, these things that might be helpful, not as techniques to protect motor neurons, but to try to improve recovery in those that have already motor neuron degeneration, I think the slow progressors or really slow progressors would be the ones you'd be looking at, would probably be the easiest to study. So I don't think this would be something that would be studied, at least initially, in conjunction with with another like if you're studying a specific agent to try to be neuroprotective, you will not also study one of these mechanisms to encourage nerve regeneration or nerve sprouting. I don't think those would happen hand in hand. What we would do is what I would say would be the most effective thing would be find the treatments that actually slow or stop ALS. If hopefully in another 5 years or 10 years from now, we'll have several others besides the two that we already have approved now. Combine those together, get the maximum amount of improvement you have, and then try to add on these therapies for sprouting and regeneration to try to see what sort of improvement we can have, right?
Hey, Greg Hayden here. Doc,
Greg.
but how is that going to help the longer living pals? Do you keep checking the newly diagnosed? How do you know how it's going to help the older ones? I've been diagnosed for 16 years. Um, Nobody's ever taken anything from me to see what I'm doing or how my body reacts. But I mean, for the ones that are 8, 10 years, how is it going to react to them for longer living pals?
Yeah. So is your question related to these techniques for improving nerve regrowth, or is your question how, if we're only doing studies in patients that are rapid progressors, how do we know that will even apply to you?
Yeah, that's it.
The second part of the question? Yeah, I
Yeah,
think
yeah.
that's a real question. It's a real legitimate question. And I think that over the years, some people have tried to study people such as yourself that have slow progressors to try to figure out, is there something different about you that allows leads to such a slow course for you. And so far, those haven't led to any real breakthroughs, unfortunately. But I agree, patients such as yourself are really important to learn from. And it is an issue, and I wish I had a solution to you. Obviously, once a medication's approved, even if it's just approved for, if it's approved for all ALS, even if it's only trialed in patients again that were the fast progressors, we would still obviously be able to treat patients with slowly progressing, such as yourself. So I think it can still benefit you, I'd hope. But you're right, we don't know. It may be that it's more effective. Maybe we're just biasing ourselves to try and find treatments that only work for patients that are fast progressors, right? And
Yeah.
I hear your concern. I mean, this ends up being an issue of finances and time and things like that, right?
Well, because
Which is not how we should really be deciding what our treatments are. But that ends up being what the pharmaceutical companies are doing, right? Is they're saying, if I can do a trial in 6 months or a year with a fast progressor, I'd rather do that than do a trial over 5 years or 6 years in somebody who's more slowly progressing.
because the ones that are longer, slower progressing, they have their progression right there on the charts. So I mean, they know how slow they're progressing. So by trying a trial or whatever, you could see if that stays with that or gets better.
Yeah.
Thank
Okay,
you.
thank you.
I hear you. I hear you.
Greg, thank you. And that's actually also a reminder of why we do the studies we do with the technologies we do to try and detect and really separate the subpopulations as they emerge, using our studies so that more studies can target different populations more precisely. It's not always, we think there's more than one way to address this challenge of timing and picking the right people. And most importantly, it's better understanding the people who are going into these studies and how they're diagnosed. So it's just another reminder to please, participate in these studies and be a part of what we're trying to do to get everybody access to trials.
Well, the only problem is any study that I put in for, they ask for 2 years or less.
Yep.
I have 16.
And that's exactly what we want to challenge. You're right.
Okay, thank you.
Thank you. We've got a few more questions because I know we're up against time. And Dr. Morrison, thank you for staying with us for it. One question is, are there Tofersen non-responders, and is it known why they are non-responders?
I would say there's differential response to Tofersen. I think that's a tough question to answer, I think, in one way. But I think there certainly is differential responses to Tofersen, so that, not some people do continue to decline for sure on even if they're getting Tofersen. We still believe that decline is not nearly as fast as it would be without the treatment. But there are some that still decline on it. And, why that is, I think, is very much unclear. Certainly we would expect that patients that are later in their course, have more motor neuron injury to begin with, are certainly going to have a harder time responding, because their disease is going to be further progressed, and there's going to be greater injury already that it's going to be harder to recover from. But beyond just the one easy answer, which is kind of just amount of time and amount of disability that has already occurred, certainly impacting the response to Tofersen, I think the other parts of the variability we don't understand. It may be that some patients have, the drug is able to get better access to the cells that are affected than other patients. But I think those are things that have not been worked out.
Thank you.
All right, the next question is, which recovery mechanisms are believed to drive improvements in Qalsody patients? And what is a recovery time frame? And is recovery seen to continue over time or level off?
So, great questions. I would say that the answer is that we don't actually know for sure which one of these mechanisms that I mentioned in this talk are really the reason why they show recovery, or perhaps one I didn't even mention, right? This has not been something that has been tested in these patients that have been taking Qalsody. And without those sort of studies, we don't really know for sure. This is more a bit of a thought experiment in terms of we see this improvement. Why do we think this improvement is occurring? More than a real definitive statement that it is. Okay. It is, and I think that, yeah. So I think I'd probably leave that at that. There was a second part to that question, though. What was the other part of that question?
The second part is, what is a recovery time frame, and is it seen to level off or still continue and progress over time?
Yeah. I think, first of all, most of us have not had patients on it that long yet, right? This is a treatment that was only recently approved, right? So except for those places where people that are following patients that were in the clinical trial have the longest history. But many patients, most of us have patients that have only been on it for a few months or whatever. Based on the trial data that I showed you, at least not really a trial, but the published data that I showed you, it looks like this improvement is certainly occurring within the first 18 months of treatment, if the improvement is going to occur. So I think that's the time frame you're looking at is 1.5 years, let's say 1 year to 2 years, somewhere in that range in terms of seeing an improvement. I don't think we know how durable it is, meaning how long it's going to last at this point, because we just, we haven't followed these patients for long periods of time yet. I think, in our own experience here, I think there is some definite improvement, and then I think there is some leveling off. I don't think it continues, certainly doesn't continue to improve indefinitely, and I wouldn't expect it to. I think there's some improvement, some leveling off, and then, many patients seem to just stay at that same level for a long time. But in terms of how long they're able to stay at that level, I don't think we fully understand that right now.
Got it. Thank you.
We're running out of time, so we're just going to do a couple more. And any additional questions, we'll try to do some overtime with Dr. Morrison and get the rest answered for you and include them when we do our recap. Since here's a question that's also kind of a comment, but I think it's worth exploring a little bit just to explain how the future will go. Since single modality treatments will likely have limited efficacy and long-term improvement, what can be done to promote combination treatment therapies? For instance, ASO therapy or to reduce cytoplasmic proteinopathy, reducing cellular stress, promoting neuromuscular plasticity and recovery. Seems ultimately combination therapies will have greatest impact.
Yeah. First of all, I agree. I think that at the cellular level, I think there's many different processes that are dysfunctional in ALS, and just addressing, with the exception of these genetic diseases where it actually is just one thing going wrong that starts the whole process, so we can target that one thing. But for most patients that have sporadic ALS, it's not going to likely be one thing. Right? There's likely multiple things that are going wrong that are leading to the disease. And I agree that the most effective therapies are those that are going to either be a single therapy that can target multiple different parts of the, we call them pathways, but multiple different functions in the body that are abnormal in ALS patients, or different treatments coming together to do that sort of thing. I think it is hard in a clinical trial setting to try to test more than one at a single time. So the hope would be that it's very easy to do studies, and this is the sort of things that are done in cancer therapies and other diseases quite frequently, is you find one effective therapy, you find effective therapy B, and then you can combine them together and see what you get between the two. That's pretty easy. And I think that will be relatively easy to be done in ALS as well. The more difficult question comes, what if, treatment A isn't quite significantly effective on its own, treatment B isn't quite significantly effective on its own, but together they might have been significantly effective, right? And I think those are harder questions to answer. I think that ultimately that's something that I think needs to be worked out in preclinical studies, right? In cell cultures and animal models and things like that. Before coming to patients. And if you really see there's this great synergy between two compounds, right? This is, this has been done in ALS before, but if you see this great synergy between two different compounds coming in and impacting the nervous system in different ways, then perhaps you can move those together into a clinical trial. But I think that comes from a preclinical studies.
Thank you.
All right, this next question is, does neuroplasticity apply to motor neurons, or is it only a peripheral mechanism? And if it happens similar to a stroke, does that mean that the brain produces new motor neurons?
So that's a great question. So I think that in general we do not think that after a stroke or in ALS, in these patients that are being treated with Qalsody or that there's any ability to produce more motor neurons. We have a set amount of motor neurons that we have, and we can generally only go down from that number of motor neurons, not up. The plasticity that we see is not by producing more motor neurons. The plasticity is by having the motor neurons that are remaining, as well as other cells that are around the motor neurons that are supporting the motor neurons, and that gets to the glia. That also gets to other neurons that are in the cortex, like in the brain, that can help kind of enhance or enhance the signal, let's say, from motor neurons. But that this sort of plasticity occurs not by growing new motor neurons, but by having improvement in the motor neurons that are remaining, as well as support from cells that are around it.
Okay, thank you. We're going to wrap this up with just one last question here, but I think it's important because it also speaks to the challenges within even households and families and the community as a whole with some of the decision making. One member of the community has a husband who's had the SOD1 gene, and to their knowledge, he's the first known in his family. And to his two sons, ages 38 and 41, have so far not wanted to be tested. There has been some statistics that say that 50% of SOD1 carriers will develop symptoms before around the age of 46. Is that true? And what's available, what's recommended in situations like those?
I mean, I think it's yeah. So first of all, this is an issue that obviously comes up with many of our patients, both with SOD1 ALS, but also with other types of ALS and other genetic diseases. And I would say it's not an easy question to answer, right? I mean, I think that if as certainly the person that asked this question is aware, if you have ALS and it's caused by SOD1, your chance of passing that on to each of your children is 50%, to each individual child. It's basically a coin flip, right? Now, if that child has the gene, SOD1 has a pretty high penetrance, which is the medical term we use for meaning that if a patient lives long enough with a mutation in SOD1 that causes ALS, they are likely to get ALS. Now, we don't know what age that will be. Saying 50% at 45 years old, that's just a summary of statistics, but that patient could get it at 30, that patient could get it at 60, that patient could get it at 70. Depending on what the specific, so we talk about it as SOD1 mutations, there's actually over 100 different specific mutations in SOD1 that actually can cause the disease. And each one is a little bit different. So that some cause disease that happens rapidly and progressive and can be even quite early in life. Some of it is a very slow disease, right? And so I think to some extent, my individual answer to the patient would depend on what the specific mutation is and what the disease course was. If I would say, though, that if a parent, I would at least counsel patients this way. If a parent had SOD1, ALS, and others in their family have had it, let's say, and weren't treated with Qalsody and had a pretty rapid course, I would think that you need to, if your child has the gene and is also likely then going to have a rapid course of ALS whenever they get it, they would need to be quite vigilant for any sort of changes to see when the earliest change they can find that the ALS is occurring, right? And so that only happens by gene testing, first of all, right? So you don't need to do it if you're gene negative, right? You're gene negative, you don't need to worry about ever getting that disease, okay? If you're gene positive, then we need to figure out what is the first changes that we can use to be able to assess when a patient is or when a person is first developing symptoms, right? And this comes down essentially to biomarkers, right? So we're looking for, what is some of the easiest tests we can use to try to see if their disease is starting to take off. One that's been used, for instance, that's used as a biomarker quite frequently now in ALS patients is neurofilament light chain, for instance, right? And if you had a base, you could follow patients with like a baseline neurofilament light chain, get it when they have no symptoms at all, and then, perhaps repeat that blood test on some regular interval, let's say every 6 months or something, or every year, depending on how you wanted to do it. And if that started to rise, that would lead you to further investigation of that person to see if their ALS is starting, right? Because the goal for these treatments has got to be to get the treatment in and started as quickly as possible. That's only possible if if a person knows that they have the gene and that they need to be watching out for things, and perhaps even getting specific studies or tests done on a regular basis to try to see if their disease is starting, right? And so if now The flip side of that would be if the person has an SOD1 ALS form that is really slow, in that case, it might be okay for the person not to get tested, right? Because they're going to start to get symptoms and it's not going to be taking off so that they're like completely weak in 3 months. They're going to have time then to get tested and get treated without having too much disability. So again, that's where it comes down to individual patients, and answers specific to their particular genetic mutation and their particular type of ALS.
Thank you. Thanks, Dr.
Can I
Morrison.
break from etiquette and just ask one question that connects a couple of dots that we started with, just real quick?
Please.
So we were talking about peripheral neuroplasticity, and I'm just thinking about, do you think there's a risk factor in terms of motor unit organization and the capacity for recovery or resilience? If you look at like oculomotor and hypoglossal that have typically much smaller unit sizes compared to limb muscles, and you were talking about sprouting and at least motor unit reorganization and plasticity, do you think that there's anything there to learn from oculomotor, or is there a limit?
So the idea would be that smaller motor unit sizes might be resistant to degeneration. I don't think that bears out. I mean, it certainly does for ocular motor, but some of your other smallest motor units are in the hand muscles, for instance, where we have fine dexterity. And there we know that those muscles are some of the muscles that are earliest affected in a lot of patients with ALS, right? So I don't think I get your point, and it's a very intriguing idea. I don't think that it holds out as perhaps the reason for this selective vulnerability, which is really the question you're getting at. Why certain areas of the body are affected first, why certain areas of the body seem to be protected in patients at least until very late in the course of their disease, which are all excellent questions and things that I was studied and was very interested in grad school and still am interested in. But I don't think motor unit size is going to be the answer there.
Thank you.
All right. We're almost at time for our full program. So I actually have one more that I think is a good commentary on kind of the state of how we're even tracking progression in diseases and our outcomes. Is Tofersen real world data? Does it serve as evidence that neurofilament light decreases at 6 months? Is that a sound approach for ALS drug development to rely on?
I mean, I think that neurofilament has great promise as continuing to be a biomarker for disease course and disease progression within ALS, right? I think NFL or neurofilament light is not a great biomarker for the diagnosis of ALS, in that it's elevated in many different diseases. But I think that this study specifically, and I think this will be borne out probably in future clinical trials as well, is that it's looking like neurofilament light chain might be a good marker here that can be used for clinical trials. Now, I don't think it's the end-all marker, and certainly at this point in time, I don't think it's for most cases, it'll be fully accepted by the FDA as the only marker. I think you need to be able to show that there are effective changes in other in motor function, in hopefully in survival as well. Although survival is a difficult thing to measure unless you're doing a really long trial. So survival is becoming a little bit less useful, I think. But I think that it is certainly an add-on or an adjunct marker that can be used. I think there's also there are some issues with SOD1. I mean, sorry, with neurofilament light chain, in that it is probably highest in patients that are more rapidly progressing and early in their course, perhaps, and then does tend to kind of burn out later on, meaning that if a patient's either has already severe degeneration and therefore is later in their course of the disease, it's probably not as good a marker later in the course of the disease or after some time, and it's also not going to be nearly as elevated in a patient that has a really slow course of their disease. But certainly for patients with a more rapid course early on in their disease, which are the ones, obviously, as we talked about already on this call, are the ones that are getting recruited for many of these clinical trials. I think that population of patients, it's proving to be a pretty effective biomarker.
Thank you so much. And here's hoping we have just as much progress in every other monogenic form of ALS, as well as the breaking down sporadic ALS and that poor definition that it is into the many types that we know that it is as well. So thanks for the work you're doing.
Yeah.
With it, we're going to wrap it up at that point. I know we've held you now for almost an hour and a half. So thank you so much for the time. Thank you for your generosity and staying with the community the way you do. Thanks for doing the work you do. And of course, thank you, Dr. Ostro, for even chiming in, and others. Thanks everybody for your questions as well.
I'd like to just ask Dr. Morrison, we had a lot of questions for you this evening. Did you enjoy having all those questions come to you and participating in our program tonight?
I thought this was fabulous. This is the first time I participated in actually one of these programs, and I thought it was great. And I'll tell you, I give a lot of talks, and there's always questions at the end of the talks, but I have to say that the depth and the breadth of the questions I got here is greater than probably any other talk that I've ever given. So the questions were great, and I really appreciate all of them, and appreciate the kind of the feedback on some of the stuff that we're working on and thinking about.
Well, thank you very much, because we want to support you in any way that we can. And when you come to our show, we feel like there's somebody out there staying up late at night thinking about us. And I'm sure that you found some excitement sometimes, and then it maybe came down, and then it came up. And I just want to say, keep up what you're doing. Thank you so very much. There's very few of you, and there's a lot of us. And we need you to take care of yourself so that you can come back and share some more with us.
Great. Well, thank you again for the invite. I really enjoyed it.
Okay. Everyone, look at that. And right in your living room. Nobody had to drive anywhere. All we had to do is want to be here. And for each of you who want to be here, it's really a pleasure that we work so hard and you show up and you gain something and we gain something. And so to each of you who have joined us this evening, you are more valuable than you have any idea. And you're probably the best detectives of ALS that the doctors can rely on. And with that, I just want to say, the time has come for us to pick out someone who you'd like to say goodnight to. And let's do it on 3. 1,
I'm gone.
3. Good night,
Sabrina.
Sabina.
Good night, Debbie.
Good night,
Good night, Debbie.
Ken Trent.
Good night, Joe.
Good night. Thank you, Rodney.
Good night, David. Thank you for the questions.
Good
Yeah,
night,
David.
Sabina.
Good night,
Good night.
Sherry. Good night, Tony.
Thanks, everybody.
Gary.
Love you.
Vaughn.
Great
Kathleen. What a pleasure, folks.
Thank
We
you.
will see you all. Elizabeth, hello out there. It's been a while. All right. Folks, we get a little attached to our extended family, and it's there's nothing better, really. So I just want to say one more time, come back and see what we have for you next.
Thank you.
Yes. Okay, Steffi, aloha.
Thank you.
And with that, Elizabeth, good night. And folks, Joe Redman, keep those hearts popping, brother.